This explainer is based on autoimmune inner ear disease, or AIED, a vestibular physician's deep review, published by Australian Dizziness Clinics. Available at australiandizzinessclinics.com.
All right, let's get right into diagnosis and the steroid trial. If you're a vestibular physician, a neuroaudiologist, an advanced trainee, or an audiologist working in the deep end of peripheral vestibular practice, you already know how incredibly tricky autoimmune inner ear disease can be to pin down. So today, we're zeroing in on a highly practical, evidence-based pathway. We want you to feel totally confident identifying AIED and managing that absolutely critical first step in care. Here is our roadmap for today. We are going to quickly cover the diagnostic challenge, the Hughes working diagnostic criteria, and how to exclude the mimics. Then we'll get into the diagnostic therapeutic steroid trial, defining a trial responder, and wrap up with some key takeaways. Part 1. The diagnostic challenge, or navigating the clinical void. Okay, so let's confront the elephant in the room right away. AIED occupies this really unique, strategically important niche because it's actually one of the very few genuinely treatable causes of progressive cochleovestibular failure. But, and it's a big but, there is no single pathognomonic test. There is literally no internationally ratified diagnostic standard. So the diagnosis? It's entirely clinical. It's like a puzzle. You have to integrate 4 key pieces: a compatible clinical picture, objective audiovestibular dysfunction, a documented response to immunosuppression, and a rigorous exclusion of clinical mimics. You really have to piece this together yourself. Part 2. The Hughes working diagnostic criteria, our practical framework. To bring some order to this clinical diagnosis, we rely heavily on the Hughes working criteria. These stem from McCabe's original observations back in the late 70s, and honestly, they're still the best framework we have. The hallmark of AIED, according to Hughes, is a bilateral progressive and steroid-responsive phenotype. So we're looking for bilateral sensorineural hearing loss, or SNHL, that progresses over weeks to months. You absolutely need to document objective audiometric or vestibular abnormalities, and then see a clear improvement or stabilization when you introduce corticosteroids. Now, before we move on, we have to bust a really common clinical myth about blood work. Yes, positive inner ear antibody serology, like the anti-HSP70 assay, is great. It absolutely supports your diagnosis. But here's the kicker. Negative serology never, ever excludes it. Remember, this is a clinical diagnosis. You cannot and should not withhold the steroid trial just because the lab results came back negative or are still pending. Part 3. Excluding the mimics and getting the tempo right. Time is actually your greatest diagnostic ally here. The disease tempo, specifically that weeks to months time frame, is your single most useful clinical discriminator. It's essentially the Goldilocks zone of symptom progression. Think about it. It's just too fast for presbycusis or most genetic losses, right? Those usually take years. But it's also too slow for that abrupt under 72-hour crash you see in idiopathic sudden SNHL or vestibular neuritis. If your patient's symptoms are progressing in that weeks to months sweet spot, your index of suspicion should immediately go way up. But tempo isn't everything. We also have to look at structure. At the very first presentation, a gadolinium MRI of the internal auditory meatus, or IAM, is absolutely mandatory. You have to rigorously exclude structural and retrocochlear mimics. We're talking primarily about vestibular schwannoma, but also endolymphatic sac tumors and demyelination. Basically, if you see a unilateral non-progressive loss, that should trigger a hunt for retrocochlear pathology, rather than just defaulting to an AIED label. Excluding these mimics is a critical gatekeeper. Whether the mimic is structural like a schwannoma, infectious like otosyphilis, or toxic, you have to rule them out. Once you've confirmed that bilateral progressive phenotype and cleared the mimics, you are directed straight to the definitive step, the corticosteroid trial. Which brings us to part 4, the diagnostic therapeutic steroid trial, testing by treating. This is really the practical cornerstone of the whole process. Because we don't have that perfect, magical lab marker, the steroid trial has to do double duty. It acts as both your definitive diagnostic test and your very first line of therapeutic intervention. If you give an adequate dose of oral corticosteroids and see a measurable improvement or stabilization in hearing, well, that's strongly suggestive of an immune etiology. You're simultaneously confirming the diagnosis and actively treating the disease during its most crucial early window. The key here is being incredibly strict with the regimen. First step, document baseline pure tone thresholds and speech discrimination. Second, prescribe oral prednisolone. The dose is 1 milligram per kilogram per day, maxing out at 60 to 80 milligrams for a full 2 to 4 weeks. And third, and this is absolutely vital, retest the audiogram objectively at 4 to 6 weeks before you even think about starting a taper. If you rush the taper before documenting a response, you are basically inviting a diagnostic error and risking a relapse.
Part 5. Defining a trial responder using objective measurement. So the trial is done. How do you actually declare it a success and confirm AIED? You need hard objective metrics. We define a clinical responder as having either a 10 decibel gain at 2 contiguous frequencies or a 12% or greater improvement in speech discrimination scores. Hitting those exact thresholds confirms the diagnosis and finally gives you the green light to begin a slow, carefully managed steroid taper. And here is a massive clinical pearl for you. Judge the trial response strictly on the audiogram. Do not rely on the patient's subjective impression. AIED naturally fluctuates, and when you combine that with the intense anxiety a patient feels when losing their hearing, subjective reporting becomes incredibly unreliable. Serial audiometry is the backbone of this diagnosis. The fluctuation and the steroid responsiveness must be proven on paper, not just assumed from a chat in the clinic. Part 6. Summary and key takeaways. Let's look at some final clinical pearls. We've covered a lot of ground, so let's lock in the essentials you can use in your clinic right away. Number 1, AIED is a clinical diagnosis anchored by the Hughes criteria. Number 2, use that weeks to months disease tempo to confidently separate AIED from the mimics. Number 3, use the steroid trial at full induction doses as both your test and your initial treatment. And number 4, judge the response to that trial entirely objectively. Rely on those serial audiogram metrics, the 10 decibel or 12% speech gain. As you reflect on this framework, ask yourself exactly how you'll apply these metrics to prevent irreversible cochleovestibular failure the next time you see an atypical presentation. That therapeutic window is so narrow. You've got to maintain a low threshold of suspicion and be completely ready to test by treating. In the next explainer, we examine investigations, audiometry, serology, and imaging. Visit AustralianDizzinessClinics.com for the full review and companion materials.